first of all, we are all happy to have this wonderful athlete, pride of our nation, winning the gold. So congratulations. So today we'll have a very simple and easy case. I thought of presenting this because it's very important as far as MCH candidate is concerned. When they see these type of lesions, what to do and how to proceed. So coming to the case history, a 42-year-old male patient came with intermittent epigastric pain of 3 weeks duration without any radiation, no relationship to food intake. He was having symptoms suggestive of gastroesophageal reflux disease since 2 years. Recently detected to have hypertension, no history of jaundice, fever, pruritus, hematemesis, altered sensorium, abdominal distension, oliguria, or altered bowel habits. No history of loss of appetite or loss of weight. No history of diabetes mellitus. No family history of gastrointestinal or any other pancreatic malignancies. Physical examination, patient was well built and nourished. His blood pressure was 160 over 100 millimeters of mercury. No pallor or no jaundice. Abdominal examination was nothing contributory. And there was no lymph node enlargement, specifically no supraclavicular enlargement. No evidence of any peritoneal deposits. Ascites. So investigations all were within normal limits. No abnormality could identified. Blood sugar was 106. So did an ultrasound abdomen which shows a normal liver, no intrahepatic biliary radical dilatation. The gallbladder was well distended, no calculate. Pancreas, head and proximal body appears normal in size and echo texture. Distal body and tail shows parenchymal atrophy. No mass lesions demonstrable. Pancreatic duct dilated, measuring 6.5 mm in the body and tail. And there was a right renal calculate. So this was the ultrasound report, and patient has having vague abdominal symptoms. So what will be the next plan of action? Any comments from the?
Yeah, well,
so patient
Dr. Pari. Yeah.
So patient 42-year-old male with abdomen pain for 3 weeks. I missed whether you mentioned alcohol. Was he alcoholic?
No, he was not ethanolic.
Okay.
Not an alcoholic.
So we got some abnormality in the pancreas on ultrasound. So obviously my next investigation would be a contrast and CT scan pancreas protocol.
Shankar?
What is the amylase lipase like?
Amylase lipase we didn't specifically checked.
Okay.
Is it a pancreatic pathology at all? I mean,
because this patient has come with epigastric pain, and ultrasound shows some pancreatic duct dilatation in the distal pancreas. I mean, obviously, the next plan is to go for a CT abdomen.
Okay, so we all think of CT scan, but this patient came with some investigation. So it was the other way around. Somebody thought in a different pattern. So they subjected him to MRI first. So is it okay to have MRI before CT?
No,
Pari?
no harm. No harm. I mean, everybody is more comfortable with CT scan. So given a choice, I'll go for a CT first. But if you have
it's
an
MRI, Prathapan, you explain the findings for us if it's an MRI. Instead of asking us the findings.
I wanted. So I will go for CT. Okay, right.
Was it MRI with Mrcp or MRI only?
MRI with Mrcp. So I will go for CT first. Okay. All right. So I will play it very slow. So this was the plain CT, I suspect. So if you want, you can have the look at the pancreas. So you can have look at the pancreas. It's the plain CT. So contrast enhanced CT and see. So the contrast enhanced CT they have not taken in a good manner, so I could not actually demonstrate. So obviously you can see something in the pancreas. Okay?
Pari?
Yeah, let me go through it. I'm just still trying to understand the images. Yeah.
Okay. So this will be the venous late arterial or venous images. So you can see this is the area of interest. So the area of interest. Then you have the delayed phase images.
Yes.
Okay. Any more image you want? I can provide.
From whatever images I could see, I think pancreas may be a bit bulky, but I don't see much of peripancreatic inflammation at this point of time. And there is dilatation of the main pancreatic duct and the side branches, starting from a point, I would say in the mid body, and then distally all the way to the tail. I'm not able to see any discrete mass lesion at the point where the pancreatic duct ends. So I obviously need to have a better look at the CT or better CT or a MRI, contrast enhanced MRI. At this point of time, my differentials would be adenocarcinoma in the body of pancreas, chronic pancreatitis with a stricture in the MPD, and 3 IPMN. Third would be IPMN. So these are 3 differential diagnoses I would entertain at this point of time. With this investigation, obviously things would change once I get more investigations. Next thing is I will ask for a contrast enhanced MRI with Mrcp.
Shankar, is that your order too?
Yes, sir. I think CT, we need arterial face images because obviously the duct is dilated in the body and tail. And at the place where there is a transition of the dilated and undilated part of the duct, we have to look for any mitotic lesion. So obviously you have to look for any mass lesion or so for that I need images in the arterial phase, late arterial phase, whether there is a neuroendocrine tumor or any other thing. So we have to rule out a mitotic lesion there. And obviously the next imaging will be a Mrcp. Yeah.
Actually, I think my priority will be IPMN first. Chronic pancreatitis next, because for chronic pancreatitis, there's no any suggestion of any calcification anywhere in the pancreas.
I was not sure. Maybe there was a specks of calcification. Was there? I was maybe I'm imagining, but I thought I saw some specks of calcification in the pancreatic parenchyma. I may be wrong.
And third one is adenocarcinoma, because there are no lymph nodes. I really do not know whether body adenocarcinoma can give rise to ductal dilatation, but there's no any because the body mass will become symptomatic only when it becomes big. Actually, there's no any a mass should be seen if there's adenocarcinoma body. I mean, that is my priority, or that's my choice. Yeah, Prathapan?
Yeah, I agree.
Okay.
The morphology of the duct with the side branches and the sudden massive increase in the duct size, I think they're all subtle indicators or a clue towards IPMN. So IPMN definitely is on card. I agree with Pata sir.
Okay. So these images. So this was the CT report. So well-defined hypodense non-enhancing lesion measuring 10 into 7 millimeter in segment 8 of liver, suggesting of cyst. Gallbladder normal. Pancreas, there was an ill-defined isodense lesion with contour abnormality, measuring 2 into 2.2 centimeter, noted involving the posterior aspect of body of pancreas. As the lesion is isodense, margin of lesions are not clear and correct size cannot be measured. Pancreatic duct dilated. Maximum diameter in the distal body 7.4 mm, tail 4.5 mm, with abrupt narrowing in the body of pancreas. Possibility of primary pancreatic neoplasm or solid pseudopapillary epithelial neoplasm. This was the CT report given for this patient. So,
but
so
that's a sad report. Sad report to pancreatic neoplasm. Yeah.
This was the report. So actually, this was the MRI. So the different sequences they have taken. So this is one sequence. This I think the fast spin imaging and so you can go through this. I can show the intensely enhanced area, and you can see the pancreatic duct. There is abrupt cut with a solid lesion somewhere here. That is my impression. So this was the first MR image. So we'll have a few more images. So you can see the MR. Concentrate on the pancreas. So okay, this is the pancreas. So this MRI shows something interesting. Okay. So I think this was the Mrcp. Or you can see.
Pari?
Yeah, Mrcp shows the abrupt stricture in the mid body, beyond which the MPD is grossly dilated along with the secondary branches. And I could see that mass lesion, but that doesn't seem to be actually causing obstruction. It's rather sitting parallel to the duct, little away from the duct. I really don't know whether that is the reason why there is a cutoff there. I can see a lesion, but I'm not sure whether that is the reason why there is a cutoff there. And I would also like to see arterial and venous images if we have, and then diffusion weighted images. All these things are important.
Diffusion weighted image, I forgot to load. But
Shankar, your take? Shankar?
It's the same thing only, sir. Nothing to add.
No. So, what is your take? You have to commit to some diagnosis.
No, obviously there is abrupt cutoff is there, and at that point of transition there is a mass lesion is there. So I would like to next. I mean, if I given a choice, I would like to do an endoscopic ultrasound and do an FNSC from the mass. I want to know what exactly it is. Obviously, MRI. I'm not comfortable in reading the MRI. So I want to know what
Shankar, you just see the image, the area of pancreas which I have loaded. You have a look at it.
No, it's clearly seen the duct is dilated and the transition point you see a mass lesion.
See, it's not chronic pancreatitis.
It's not chronic pancreatitis because there is no parenchymal atrophy.
It could not be adenosia also that level because adenosis, I do not know whether the body lesions can give rise that much of a ductal dilatation. Still, I think the IPMN will still be in the lead.
So I think I will include the possibility of neuroendocrine tumor also.
Neuroendocrine, okay.
Was a contrast MRI done, or is it just plain MRI, Prathapan?
I think they have done a contrast MRI as well. Actually, I got these images.
Can you see the arterial and venous images if we have?
There were 5 or 6 sequences they have taken, and they have taken contrast, gadolinium contrast also. But I don't have that image. Yes. I want, if you want, I can note after checking the system. I don't have in this.
So what is the next step?
Next step.
Yeah, Pari?
Yeah, so I need to really carefully study the MR images. So the differentials here include adeno, possibility of neuroendocrine, and possibility of IPMN. These are the three differentials. I like to do some tumor markers, CA99, chromogranin A, to complete the investigations. So in my mind, I think we are looking at various differential diagnosis, which all would lead on to a surgical plan of resecting that area. So, and because the differential diagnosis includes adenocarcinoma, which is known to cause metastasis, the body of pancreas is known to have metastasis diagnosis. So I will also do a PET CT. If the chromogranin A comes up high, I will do a DOTA PET. If the chromogranin is normal or CA99 is high, I will do a FDG PET.
Okay.
I'm not very keen on tissue diagnosis at this point of time, because all my differential diagnosis points to a surgical plan as that treatment.
But Shankar is contemplating an endo ultrasound tissue sampling. What is your point on that?
I'm really not very keen in this particular case, because even if it's adeno, all I want to know is whether it is metastatic, because it appears to be resectable. Even if it is neuroendocrine tumor, I want to know whether it's it looks resectable. So I just want to know whether it is metastatic or not. And we know that the patient has symptoms and it's a resectable lesion. So none of the differential diagnosis has a non-surgical treatment as the treatment option. So I'm not very keen to actually go after the tumor on an endo ultrasound and biopsy.
Shankar, any rejoinder to that?
Sir, actually, I'll do the tumor markers, and I don't have adenocarcinoma as a possibility in this patient, because considering the age and there is no evidence of chronic pancreatitis. So my thought process is in terms of either a neuroendocrine tumor or an IPMN. More in favor of a neuroendocrine tumor. That's a gut feeling. So I will do an endoscopy also to have a look at the ampulla. Is there any mucus extruding out of the ampulla? So I'll do an endoscopy, side wing scopy, see the ampulla, tumor markers, and I want to know what is a radiologist's impression on the MRI. What is the final game?
What is your thing on PET CT?
Pardon, sir? PET CT. PET CT, I mean, I'm not considering adenocarcinoma as a possibility. So I will not do a PET CT at this point of time.
Okay.
Because it's a tumor of, it seems to be a well-defined lesion, which is unlikely to be an adenocarcinoma. Adenocarcinoma, it should be a vague lesion, so you don't have a periphery, clear, very well-defined tumor. A well-defined tumor, I think in terms of either a neuroendocrine tumor, that's my diagnosis. But of course, neuroendocrine tumor means it should have typical enhancement pattern and all. But at the same time, even if you're talking in terms of adenocarcinoma, that should show a hypovascular tumor. So it's a atypical tumor there, and not having the classical radiological appearance on a pancreatic protocol CT. That's why you have brought in another imaging in the form of MRI. So I will need a tissue diagnosis in this patient.
Okay. So we have done the tumor markers for this patient. CA99 was normal, and chromogranin was showing only a marginal elevation. It was showing. So we did that. This was the CA99 report, that was 17.3, and serum chromogranin was 112. Up to 100 nanogram per ml was normal in that results. So what is the take? So we did an upper GI endoscopy that was showing the Hill's grade 1 gastroesophageal reflux, hiatus hernia, and ampulla was normal. So a patient with a normal looking pancreatic duct in the head and body and a dilated lesion in the body, the tail region, can it be producing mucin and fish mouth ampulla, Dr. Shankar? You were mentioning.
No, in this case, I'm not sure. I mean, my IPMN is not my first choice.
Okay.
Yeah.
So they did an endoscopic ultrasound, and that showed a well-defined heteroechoic lesion noted in the body of pancreas, measuring around 1.8 into 1.2 centimeter with dilated PD. Pancreatic duct measures 7 mm besides the lesion. Normal pancreatic duct in the proximal part of body and head. Superior mesenteric vein, splenic vein, and portal vein appeared normal. Their impression was it can be IPMN bar solid pseudopapillary neoplasm. So they did a US guided FNA, and they got a report like this: cellular aspirate consistent with neuroendocrine tumor grade 1. So the imaging was not very typical of neuroendocrine tumor, and it was not typical of adenocarcinoma, and it was not typical of IPMN as well. So when you have imaging not conclusive of anything, I think it's better to go for a tissue diagnosis rather than going directly to surgery. What is your take?
Yeah. Actually, I would have gone with Pari in terms of biopsy, because the lesion is very small and it looked like eminently resectable, and the surgery for that is not a very grave or a risky surgery like a Whipple's procedure. So I would have thought of going straight in for surgery. Maybe I may not do PET CT, because as you see that the lesion is within the pancreatic parenchyma and is not expanding the parenchyma, and there are no any suggestion of lymph nodes. So adenocarcinoma is not in my mind, and it's IPMN is what I was thinking from the beginning. Then if not IPMN, then neuroendocrine comes next. So either way, we're going to resect, and I would have thought of resection, of course. But then you have done an endo ultrasound. It's well and good, and that was suggestive of something. That's also quite well and good. A comment from both of them, Pari and Dr. Shankar.
Yeah, I think I already mentioned what I was running in my mind. This particular lesion, I really don't see a diagnosis where I'm going to manage it conservatively. So all my diagnosis, the treatment is going to be resection. So I'm really not very, if I have a diagnosis, that's fine. Otherwise, tissue diagnosis is not very important for me in this particular case.
So one small point here, sir. Why you need a tissue diagnosis in this case is because though my diagnosis is not adenocarcinoma, but since that has been brought as a differential diagnosis, the treatment differs. Suppose if it's going to be an adenocarcinoma, you have to go for a distal pancreaticosplenectomy, radical surgery. Whereas if it's going to be a neuroendocrine tumor, you can just do a central pancreatectomy. So it makes a lot of difference in getting a preoperative diagnosis. So that is my opinion.
Yeah, I think that's pretty reasonable. Yeah.
So this was the grading for information. There was some modification in the WHO classification 2017. They have included new groups like MI-NEN, that is mixed neuroendocrine, non-neuroendocrine neoplasm, and they have divided grade 3 tumor into two, and that is grade 3 PNET and grade 3 pancreatic neuroendocrine carcinoma. So this is looking at the mitotic index and Ka67. So we did a chromogranin, and we mentioned everything about that. So you can have chromogranin elevation in other conditions as well. So it's not very specific. You have to stop PPI and other things before you should look for mammogram. So I think these are the importance of doing biomarkers in neuroendocrine tumor for diagnosis, follow-up, identify therapeutic response, to define surgical effectiveness, to define aggressiveness of remnant disease, to predict treatment relapse and prognostic importance. So do we really require a functional imaging in this case? That is the next question I wanted to ask. So we got a report of grade 1 neuroendocrine tumor, a very small lesion confined to the pancreatic body where direct surgery is possible and there is no functional syndromes associated with it. Only a cystic lesion in the liver, which is not suggestive of a med surgery. So what is the role of functional imaging in this case?
Ari?
Yeah, I don't think we have a definitive answer in the literature, but in my view, I think I'll do it because it's a very non-invasive thing, and we'll have a baseline over which we can compare in future. In case there is any suspicious lesion in future, I would always be comfortable if we have a baseline .NX scan, because you mentioned that chromogranin is slightly elevated and the tumor, I mean, the imaging is suspicious of neuroendocrine. I will get a baseline .NX scan.
Shankar?
Sir Patta sir, you must be remembering in one of the pancreas club meeting, we had a nuclear medicine person from Miyot Hospital.
That's right.
He was suggesting a DOTA scan plus FDG PET for all neuroendocrine tumors.
Yeah,
So
yeah.
if cost is not a constraint, because now they say FDG PET and DOTA, you can assess the biological behavior of the tumor itself. We know that a PET positive NET behaves differently from a PET negative. So, I mean, definitely, if cost is not a constraint, you can do both the PET scan. But the lesion is quite small, so you can always resect it. So, I mean, I think it has to be decided based on the logistic issue rather than scientifically better to do. Yeah.
Yeah, I agree with Shankar, sir.
You may get some liver lesions which are not seen on a CT scan, for all you know. I thought any neuroendocrine, the size is no criteria, but it should have functioning imaging. You may see some lymph nodes nearby, you may see some liver lesions. Baseline, I mean, as Dr. Paris says, it's not an invasive thing, and if it's available, should be done, is my take. Yeah, Pari, you're saying something.
Yeah, important point Shankar sir was saying. If such lesions, I mean, diagnosis of a neuroendocrine tumor, we usually start off with DOTA PET, and if the DOTA PET is negative, we always follow it up with FDG PET, because if FDG PET is positive and DOTA negative, these tumors behave more like adenocarcinomas than neuroendocrine tumors. So that's a very important point. And if it's a huge lesion, huge tumor, or multiple lesions, if all the lesions do not take up DOTA PET, the .NX scan, then we also follow with the PET, I mean FDG PET, because some of these lesions may be PET positive, I mean FDG positive, and some may be DOTA positive. So that is also another important point to note.
So the literature, the indications for doing a DOTA PET is to exclude more advanced disease prior to surgical intervention, to localize primary tumor in patients with biochemical suspicion of neuroendocrine tumor, to identify primary tumor in patients with non-metastatic neuroendocrine tumor, because more than 50% tumor presents with metastasis. So to confirm diagnosis of neuroendocrine tumor in patients with anatomic lesions that are suspicious of neuroendocrine tumor, and to identify patients who are likely to benefit from octreotide therapy or PRRT with the lutetium 177 or yttrium-90. So if you go by the literature indication, the only first indication you can apply to exclude more advanced disease prior to surgical intervention. So looking at the lesion size and the other rest of the abdominal organ, there was nothing to suggest a metastatic disease, but I do agree with the views of moderators, because we can do, but it is not available it has to be done from outside, costs around 22,000 rupees. So the next indications for doing an FDG PET and CT with the use of somatostatin receptor PET CT. When you have Ki-67 of more than 5%, worrisome lesions with little or no activity on CT, a component of somatostatin receptor PET CT, and clinical or radiological progression within less than 6 months, despite Ki-67 index of less than 5%. So these are the definite indications for doing FDG PET along with the somatostatin receptor PET CT. So these were the things mentioned by moderators. So the diagnosis of neuroendocrine tumor depends upon clinical presentation and tumor location, symptoms due to hormone hypertension, and you have to need estimation of specific hormone levels. You can use tumor markers and histopathologic analysis, demonstration of neuroendocrine markers, examples and tomogranulin in tissues. And the expression of these things are limited in poorly differentiated tumors. So when you have very high risk, high grade tumor, poorly differentiated tumors, don't expect these neuroendocrine markers even in tissues. So these are the indications for morphologic and functional imaging and invasive techniques in pancreatic neuroendocrine tumor. You can go through the slides. So if the tumor size is less than 2 centimeters, endoscopic ultrasound guided fine needle aspiration for histopathologic evaluation is indicated, because some of the lesions we may manage conservatively. So there are literature support for using endoscopic ultrasound for suspected neuroendocrine tumors as well. So these are the evaluation technique. Tumor suspected clinically when you have raised biochemical markers, then go for functional imaging assessment. The tumor is suspected on anatomic image, again go for the biochemical marker, and finally you have to do functional imaging assessment. So as a part of workup for neuroendocrine tumor, it is advisable to do a functional image. That is the view. So what next for this patient?
Pari?
Yeah, assuming we have a neuroendocrine tumor in the body of pancreas and there's no metastasis, I have two choices whether to do a distal pancreatectomy versus central pancreatectomy. Both of them appear possible. And in my view, it is the tumor is rather on the distal body. I would rather go for a distal pancreatectomy.
Shankar?
Sir, in this patient, I would plan for a central pancreatectomy because since it's a low-grade neuroendocrine, so better to conserve the pancreatic parenchyma. And duct is dilated, so I can do a good anastomosis. So my plan will be to go for a central pancreatectomy. And as far as Prathapan was telling about conservative treatment of small neuroendocrine tumor, suppose you have a neuroendocrine tumor of less than 2 centimeters in size, which is picked up on an imaging done for some other purpose, like an incidentaloma. Then literature says that you can treat, you can follow up these patients. But in this particular patient, patient is symptomatic and the duct is dilated. That's very worrying. So once you resect this tumor and send it to give the whole specimen to the pathologist, we may get a different Ki-67 index also. So that's also have to be kept in mind, because why the duct is so much dilated. So this patient definitely needs surgery, and my choice will be to go for a central pancreatectomy.
Yeah, actually, I go with Shankar because this looks like it's got a reasonable tail, I should say. You know, I don't want to lose so much of a pancreas, and central pancreatectomy looks very much in. But the only issue is, exactly localizing the lesion and getting proper margins is an issue. But I would rather prefer. Somebody is asking about lymph nodal dissection if it's neuroendocrine tumor. If lymph nodes are positive on Dotanac, then maybe I will try and remove the lymph nodes in the neighborhood. But otherwise, I will not be so much bothered about lymph nodes. A word about lymph nodes from both the moderators.
Yeah, I'm not really too much bothered about lymph nodes. If I see obviously enlarged nodes, and I would probably remove them along the splenic artery. Otherwise, I'm really not concerned about lymphadenectomy.
Shankar?
Okay.
Yes, sir. I mean, lymphadenectomy is recommended for NET surgery, but this lesion is too small, and you can always do a berry picking or sampling the, not a formal lymphadenectomy.
So we vote for central pancreatic. Prathapan.
Okay. So I didn't do a central pancreatic. I am not in favor of doing this. So
Why aren't you in favor? Why aren't you in favor? Any reason?
No, sir. The lesion is not exactly in the body. It's only part of the body can be saved, and distal pancreatectomy will not produce that much loss of pancreatic tissue when you compare the total amount. Around 60% of pancreatic parenchyma is contributed to the right of neck of pancreas. So, if possible, you can conserve, but there is a risk of anastomosis. And if you leave that area, there are two cut margins. And if there is a leak, that can produce problems. But even though in a patient with a dilated duct, the risk is less. So I didn't think of doing a central pancreatectomy in this patient, because I usually do central pancreatectomy for benign type of conditions, not for a tumor like a neuroendocrine tumor, or not for adenocarcinoma like lesion. I do it for a small spen or some cystic lesions where there is no evidence of malignancy. So when you
basically,
consider the possibility,
Prathapan, central pancreatectomy is recommended for benign conditions as well as low-grade malignancy, or a pre-malignant condition like an IPM. So I mean,
it's recommended, but when you go by the literature, there are literature not in favor of these sort of procedures, thinking in terms of leak and issues related to additional pancreatic anastomosis. That is one point I have to make. And there is no harm in doing a pancreatico-jejunal anastomosis for the distal stem after resecting the central part of pancreas. So I do occasionally this procedure, but the view is well accepted.
Yeah, okay. But one thing we have to stress very clearly is that if it is an adenocarcinoma, no central pancreatectomy. So yeah, that has to be stressed very clearly.
Okay, so what are the indications for observation? This non-functioning tumor less than 1 centimeter, it has to be of grade 1 with a very low Ki-67, and it has to be asymptomatic. There should not be, there cannot be a dilated pancreatic duct, and non-functioning neuroendocrine tumor 1 to 2 centimeter. There are literature using observation studies, but majority of surgeons are in favor of doing surgery for lesions 1 to 2 centimeter. So here the lesion is between 1 to 2 centimeter with symptoms and pancreatic duct dilatation. So we have to go for surgery. So we did an open surgery in this patient, midline with left subcostal extension, because patient was very hefty and very obese. I could not handle that area. And there was a solid lesion in the body of pancreas towards the posterior aspect. Splenic vein was adherent to the tumor, and pancreatic duct was dilated, enlarged splenic artery and left gastric lymph node, which was not seen in the images available. And the surgery was delayed around 1 month after the CT scan. So the liver showed a small cyst in segment 8, and rest of the abdominal organs were within normal limits. So we did a distal pancreatectomy with splenectomy and lymph nodal dissection. So the pancreatic duct at the neck margin was undilated and closed separately using PDS, and pancreatic stump closed using 4-prolene with interrupted sutures, and drain was kept. So this was the lesion on intraoperative image. I was pointing to the area of the lesion, but the lesion was on the posterior aspect of pancreas, not on the anterior aspect. So we did this, and very little stump part of pancreas is left behind after your dissection. So you can see the total length of pancreas, and the lesion size is also very small. You can see the lesion more towards the cut end. So there was a 5 mm margin from the cut end only, but this was the lesion. So this is the total length of pancreas removed. In
can you show the lesion with your pointer?
I will show you. I can show. This is the area of.
Okay.
Prathapan, just one question before you proceed. Did you have a plan of doing a spleen preserving distal pancreatectomy in this patient?
So I was thinking of spleen preserving distal pancreatic, but you asked why there is ductal dilatation in that area. There was some amount of fibrotic bands in that area of the pancreas, which was looking like some local extension of the tumor. So I was thinking of doing a formal resection, because to save the spleen and all, we may have to shave the pancreatic area from the spleen. And if it happens to be something different in the post-op, we can have problems. So you can see the dilated duct, which is at the end of the tumor is seated at the end of dilated duct, and that was producing the obstruction rather than the compression from outside. So the lesion was in the near the pancreatic duct, more towards the pancreatic duct. So I didn't do spleen preservation because
Prathapan, before that, in retrospect, would you have considered a central pancreatectomy, because there's so much gland that's taken away?
No, sir. Parenchyma preservation is an option. I will just go through the next slide also. Then
okay. Now you're talking something about spleen sparing.
Yeah, spleen sparing surgery has to be done in patients where you have to go with resection, especially when you have multiple tumors, when you have to save the pancreas and all. Spleen preservation is possible in majority of the lesion, where you can have two types of procedures. One is the Warsaw procedure, and other is the Kimura technique, depending upon whether you preserve the splenic artery and vein, or whether you resect the splenic artery and vein, only sparing the short gastric circulations. So we do both techniques, but doing the Kimura technique is easier because the risk of splenic vein thrombosis and hypersplenism is less, or the hypersplenism in the post-op is less with this procedure. The final HPR, distal pancreatectomy, showing a fairly circumscribed neoplasm. The tumor size has increased. It has increased to 3 into 2.5 into 1.5 centimeter in the post-operative specimen. That is what they measured. No lymphovascular invasion or perineural invasion. Mitosis 8 to 10 per 10 hyperfield. Peripancreatic and left gastric lymph node, 1 out of 6 shows metastasis. So immunohistochemistry, chromogranin diffusely positive in tumor cell. Ki-67 index shows around 10% positivity focally, and their diagnosis pancreatic neuroendocrine tumor grade 2. So any difference of opinion in the management when you have higher grade tumor with lymph node mets?
Sorry?
So because the lymph nodes are positive, the Ki-67 is greater than 5. So this patient needs to have a metastatic workup if it's not already been done. So we need to get a PET, Dotanac, and FDG PET, at least in the post-op, as a baseline. And if there is any metastasis, they need to be taken care of with the lutetium therapy. So I will do a post-op PET like 6 to 8 weeks, maybe 2 to 3 months later to follow, because he has lymph node positivity. And a few things I would have done different is all the patients, irrespective, I would have given a pneumovac vaccination, because sometimes you don't.
We have given to all patients. We are good.
Fine. And even if you had to take the splenic vessels because they appear to be tethered, it's not necessary that spleen has to come out. If you had, I always make sure that the left, the right, the gastroepiploic arcade is preserved. I make sure that its connection to the GDA is preserved. In which case, even if you take off the splenic vessels at that point where you felt it was tethered, you not necessarily have to remove the spleen all the time. So spleen could still have been preserved if you wanted to.
Shankar, your comment?
Yes, sir. As I was telling, the dilated duct was giving an indication regarding that it may not be a grade 1 tumor. And finally, it has come with some mitotic activity and grade 2 tumor, and lymph node is positive. So retrospectively, what Prathapan has done seems to be a correct way of where he has done a distal pancreatectomy with lymphadenectomy. And definitely this patient needs workup, staging workup, as Dr. Pari was mentioning, post-operatively.
Yeah,
and within a short period of time, there seems to be a tumor increase in size also. So we know that neuroendocrine tumor are very heterogeneous tumors. The behavior is unpredictable. So, I mean, this patient needs to be very followed very diligently. Yeah.
Okay. So the follow-up plan depends upon what is the grade of tumor and what is the type of initial investigations we did for these patients. So as Pari was mentioning, you have to follow up this patient for at least 10 years. And for every 2 months, for first 6 months when the tumor is of grade 3, and every 3 to 6 months for after surgery, every 6 to 12 months for 5 years. And then every 12 to 24 months for 10 years, and every 5 years till the next 20 years. So this is the way you have to follow up this patient, because the patient can have recurrence or metastasis at any point of time in their life. So when you have a resected disease, these are the different societies guideline. One is the French guideline. The second is the NCCN guideline. The third is the Commonwealth Neuroendocrine Tumors guideline, and then is the European Neuroendocrine Tumor Society guideline and ESMO guideline. So the North American Neuroendocrine Tumor guideline is not included in this. So when you have a grade 3 tumor, you have to have very aggressive follow-up with the biochemical markers, clinical examination, plus CT scan bar MRI every 3 to 6 months for 2 to 3 years, and then every 6 to 12 months. And when you have advanced disease, you have to do contrast CT and MR, biochemical markers if positive, then every 2 to 3 months, if on therapy, you have to do all these investigations. So the follow-up of these patients is not very easy. You have to have very aggressive follow-up when these patients have grade 3 tumor, they behave like an adenocarcinoma. But if it's a grade 1 tumor, the follow-up period is same, but the interval of investigation is less. So there is a neuroendocrine tumor recurrence risk score by Zaidi and Lopez, published in Annals of Surgery in 2019. When you have this is a RRS scoring system. When you have asymptomatic tumors of less than 2 centimeter size, score is 0. When the tumor is symptomatic, score is 1. When the tumor size is more than 2 centimeters, score is 2. K67 less than 3%, score is 0. 3% to 20% score is 1, and more than 20% score is 6. Lymph node negative score is 0, and lymph node positive score is 1. So with this RRS scoring system, when you have a score of 0 to 2, they are classified as low risk for recurrence. When it is 3 to 5, intermediate risk, and when it is 6 to 10, it is high risk. So the neuroendocrine tumor, even if grade 1 tumor, you can have recurrence and metastasis. So follow-up is recommended for these patients. So I thought of discussing this small tumor because it makes our life miserable.
So I think it's an interesting case and did generate some good discussion. And I think we have some very good points we come across, especially the role of PET-CT and the role of FDG-PET and DOTANAC, and also FNA, endo-ultrasound, and whether to go in for distal pancreatectomy or central pancreatectomy. I think, and about the role of lymphadenectomy. And there are a couple of questions in the chat box. I don't know whether Prathapan, if you're, yeah. Niket is asking some questions. The liver lesion is metastatic on imaging. What would we have been the approach?
I have mentioned that in our discussion, every 3 months you have to repeat. It is after resection. So I don't think there is any need of repeating the CT scan within a month time, because this patient has a lesion which is producing some symptoms, and we have done an FNA and showing neuroendocrine tumor grade 1. So if it is a high grade tumor and the patient has symptoms worsening, we may have to think of doing repeat imaging within 2 months or 1 month. So if the patient is not having worsening, I think the grade 1 tumor, no need of repeating the image immediately.
No, I guess the question was what if there is cyst, liver cyst, which was seen in segment.
That is the other question.
Actually,
that's
no, that's the next follow-up question. Yeah,
that's the next question.
Prathapan is answering the previous question.
Oh,
so I have observed that was a cyst, and I just ruptured it during the procedure. I forgot to mention that cyst I could handle during the first surgery itself. That is only a cyst.
No, that is okay. That you ruptured it, that we know is cyst. His point is, if it is a lesion, it's neuroendocrine secondary, what is that would you do? There's an exam question.
If that is secondary, or even if that is not the current guidelines indicate, you have to do a functional imaging for metastatic workup or looking for lesions elsewhere. I think neuroendocrine tumor, in exam it is easy. You can identify the lesion. It's suspicious of NET. You can opt for a functional image if it's available. It is not like the other type of tumors where you say PET-CT or PET scan. The examiners won't accept. But here, doing a functional imaging is a well accepted indication.
So would you do a metastatectomy? Would you do some sort of a segmentectomy? What would you do for that in case if it is a? Or you
Sir, we do a metastatic resection. We have discussed one advanced neuroendocrine tumor, one of the clinics. I think if it's a well localized lesion, there is no need for a, even in metastasis, other colorectal metastasis also, the non-anatomical resections are favored in the lesion is located in the periphery. It's not like hepatocellular carcinoma. The resection method is different for metastasis, because you have to preserve maximum parenchyma without the risk of developing liver failure. So the tumor resection with the margin is well accepted rather than going for standard anatomic resection in metastasis. Moderators can have their views.
Answer is metastasectomy. So I assume the question is, you do a proper metastasis workup in the preoperative period with FDG PET and DOTANAC, and then we assume that was the only metastasis detected. So the answer is, we have to do the primary surgery and then metastasis resection during the same sitting. That is the answer. And as far as cyst is there, I would not touch it. I would not rather go and break it. I will just leave it, let it be.
Why that?
Why would you break this?
So, what is the treatment of? So it may grow, no?
Shankar?
Okay. So, Prathapan just want to know, after the post-operatively, you want us to do chromogranin every 3 months. What is
So it's a recommendation by the society. But this patient was having a normal chromogranin prior to surgery. So I don't think there is a role for patients who had normal chromogranin prior to the resection. So if they have an elevated chromogranin level, or if they have a functional image done previously, you have to repeat those things. Otherwise, I don't think chromogranin has a role, because elevated chromogranin preoperatively means when you do resection, there is a role, but I don't think a normal chromogranin has a role, especially in a normal chromogranin.
Actually, I have a problem with this chromogranin mainly because for a non-scientific reason. It's the chromogranin is extremely costly test.
5,000
Not like your
rupees.
CE or CA 99.
It's 5,000 rupees.
Yeah. Yeah. So it will be a logistic issue.
Now, I would still do chromogranin A in spite of the preoperative chromogranin as low, because it could very well be a false result or whatever. At least once or twice, I would certainly do a chromogranin A in the follow-up. I mean, there's nothing against it.
So recently I had a case.
Yes,
See, in this case, it is slightly elevated actually. If I remember right, 100 is the upper limit and it's 112. In this case, I will do it once in the post-op, like after 2-3 months. If it has fallen down, then I am concerned that actually this may be useful in follow-up. Suppose after 2-3 months, I do it again and it is like 20 or 15. I know then probably I will keep it in mind and probably I will use the chromogranin in my follow-up. It is slightly elevated. If it was actually 15 with the upper limit being 100, I would not do it again. But here it's actually slightly elevated. So I will at least do it once in the post-op period.
That's a good point. Yes. Okay. Any other comment from anyone? Somebody is commenting on PRRT. When will you give? Prathapan, you can.
PRRT is indicated for metastatic neuroendocrine tumor, where you have somatostatin receptor positive tumors imaged on the FDG, not the FDG, what you call
gallium DOTA PET, or even SPECT scan, because the receptor has to take the this radioactive material towards the tumor. So it will give local beta radiation to the tumor cells, and that take care of the tumors. But the volume of tumor is an issue. When you have a large volume tumor, we can't give this sort of treatment, where you have to combine resection with PRRT in these patients. So PRRT is an option for metastatic neuroendocrine tumor where resection is not possible and the volume of tumor is not very high. Prathapan, just to complete the discussion, can you just tell us there are different types of treatment for neuroendocrine tumor apart from surgery? One, you can give somatostatin itself. Second one is PRRT, and third one is to give chemotherapy. So,
chemotherapy is
what's the broad principles? Yeah,
there are I think three form of therapy. One is the receptor manipulations, like giving somatostatin receptor. You have the long-acting somatostatin receptor analogs, either what is called octreotide LAR or the lanreotide. There are trials which indicates decreased tumor progression, because initially they all started for functioning tumors, but they found that there is decreased progression of the tumor. So they are all tumor is static when you give these somatostatin receptors, but that will not stop the tumor. It may divide. So you have to give it for lifelong, as long as the patient is alive. So that is one form. Then you have these kinase receptors inhibitors like the sunitinib trial. There is a trial called sunitinib trial on this neuroendocrine tumor. They are all receptor level manipulations. Then you have the chemotherapy that is basically used for grade 3 tumors where the neuroendocrine, the somatostatin receptor scanning is negative, but FDG is showing positivity, where you manage with chemotherapy. Streptozotocin based therapies are given. There are The third method is to give mTOR inhibitors. Like there also the mammalian target of rapamycin. They use this what you call mTOR inhibitors used in the treatment of advanced neuroendocrine. They all prevent progression of the growth of tumor. They are actually not tumoricidal, but they prevent progression of these two. mTOR inhibitors, everolimus is also used for treatment of metastatic neuroendocrine tumors. Okay.
So I think we had a wonderful discussion, and it's a nice little case with thorough discussion, and there are no more comments from anyone. Thanks everyone. Thanks Prathapan. You take great efforts in getting the Saturday case ready, and they make Saturday worthwhile. Thank you so much. We'll see you again. Another case coming Saturday. But Monday we are having one very exciting session. We are starting off anastomosis. I request all of you to be around, and Ilongo is starting with the small bowel anastomosis. So we need to dissect the whole thing out so that a lot of students will benefit as to how exactly. And if any one of you have any videos of small bowel anastomosis, please be ready. So we'll also know your techniques of Prathapan, Pari, and Shankar. Thank you.
Thank you, sir.
And we'll
Thank
see
you, sir. Bye. Good night.
Monday. Take care. Bye-bye.